So this patient is a taxi driver. He presents with about a day's history of bleeding, vomiting blood. Okay. So once has it, you need to ask, Rachel, you need to ask for every presenting complaint. Please, you need to ask whether it has happened before. Has this happened before? It's safe. Okay. Has this happened before? I mean, after you've established the duration and all. So has this happened before? We need to know. And for the bleeding, yes, you did well by first, you want to know the color, because you know that whenever someone has an upper GI bleeding, it could be variceal. You first need to establish if it is variceal or non-variceal. And although not 100% screening tool, usually non-variceal blood is what? Coffee ground, altered. Once you hear the coffee ground, then you are thinking of more of what? A non-variceal bleeding. And the variceal is relatively bright red. It is relatively bright red. It's not digested like the coffee ground. So you need to know the color of the vomitors, what he considers I'm vomiting blood. What is the color? Then yes, you did well to assess the amount. And whether there are other sites of bleeding so that you don't miss any systemic problem. Other bleeding sites. And whether they have any associated anemic symptoms. So you could have asked, although you did for some, I saw that you're asking the systemic inquiry, that is fine. Dizziness, lightheadedness, lightheadedness. You have asked for feeling of the heartbeat even at rest, that's palpitations. You have asked for headaches, whether he has fainted or has fainting spells, that is what syncope and all that. So once you are done with this, now what have you done about it? And then you came to see me. On direct questioning, remember that you are looking for the underlying cause and then the complications. So the first C is the cause. Now you've got to understand that, like I said, whenever someone has upper GI bleeding, it is either variceal or non-variceal. The variceal causes are related to what? Portal hypertension, non-variceal, non-portal hypertension. And for the non-variceal, the prototype is actually a bleeding peptic ulcer. The prototype or the representative of non-variceal sources of upper GI bleeding is from a bleeding peptic ulcer disease. Then here it is from a ruptured esophageal varus from a portal hypertension which has cirrhosis as what? Its most common cause, 80% of the cases. But there are other causes here. So like a bleeding gastric tumor, and esophagitis. You can have malarivitis tear. And it goes on and on. And here you can have your Bad-Chiari syndrome, a whole lot of funny things. But for the variceal, it is okay to actually remember esophageal varices. So having gotten the clue that it may likely be a non-varicial bleed, you think of what? PUD. So you know the questions to ask for PUD. Is there a history of a recurrent gastric pain associated with meals or hunger? That is what? Recurrent dyspepsia. So you're establishing the symptoms first. Those are your important positives. Okay. Then you want to find out if there are associated heartburns. Doesn't point to the ulcer per se, but it gives you an idea. You want to find out whether, if he has the recurrent dyspepsia, you want to find out if food, what is the relation to food or hunger? Does food improve it? Does hunger improve it? All those things. Now, these are almost, the things you can talk about, on a large scale. You quickly come to the risk factors, and you're asking about what? Alcohol use. You're asking of steroid use. All these can be gotten from what? The drug history. NSAID use. So you ask whether he uses any painkillers for any reason. And for a woman, dysmenorrhea. Sometimes the NSAID is used for what? Medical conditions like arthritis and all that, spondylosis and all that. Is that okay? Yes. Are we good?
Yes.
Yes. Good. So you can go on and on for this. So saying this, you have about 5 ODQs. Okay. You come to the gastric ulcer or the gastric cancer, I wanted to say. You want to ask for a history of weight loss. You want to ask for a history of early satiety. And whether he feels feeling of a mass in the epigastrium. And whether there is what? Malaise, weakness. You are thinking of a malorivised tear. Was there any violent vomiting? You've already asked for alcohol. Violent vomiting preceding the bleeding episode. Ask for alcohol, so malorivised tear. You are thinking of a possible esophagitis, so the heartburns has taken care of it. So you see that 1, 2, these are enough questions. You don't ignore the esophageal varices, okay? So for the esophageal varices, you know that cirrhosis is what's the most common. And like I'm telling you, if you know what you're asking, it might seem that these questions are a lot. And Rachel, I've told you, try and stop, avoid that. Do you cough? Then you go and write and come back. Although I'm not seeing you, it felt to me like you asked for systemic inquiry and you took a long time there. But luckily for you, because the history was straightforward, you were able to finish on time, like right when the bell rang. You can ask cough, and you can write no cough. He says no, move on. What he says here, that's what you go and document. Or any question that comes to you, you can ask for systemic inquiry. The candidate asked. So esophageal varices, ask for any yellowish discoloration. Ask for any abdominal swelling, abdominal or leg swelling, 2 legs swelling. Ask if he knows his hepatitis B or C, status. Okay, this is about enough to tell the examiner that you're thinking of a liver pathology. Then after that, the rest of the history goes on like you said. Excellent. So when you are asked to summarize a case, I've done this with you already. It is so simple. Present a diagnostic illness script. I have said this here before. I have seen 46-year-old Mr. Abina Mensa who presented with coffee ground vomiting of a day's duration associated with anemic symptoms. He abuses NSAIDs and there is no history of jaundice, abdominal swelling, or weight loss. Anyone who looks at this clinical vignette, if you give him A, B, you say the correct thing. Coffee ground vomiting, anemic symptoms, NSAID abuse, no jaundice, this, then it's likely that his upper GI bleeding. What is your diagnosis? You would say a bleeding. You said duodenal, but you are not sure. You can't stick out your head like that. A bleeding PUD complicated by anemia, isn't it? Your differentials would include a bleeding gastric CA, malarious tear, bleeding esophageal varices, esophagitis. The thing goes on and on and on. Is that okay?
Yes.
Is everybody okay?
Yes.
So what investigations would you do for him? Of course, you would want to do an upper GI endoscopy. But before I do that, I would want to start with things that would save him first, okay? So I would want to do an urgent FBC, but you mentioned all those, that is fine. Grouping and then cross-matching against at least 2 units of blood, because I'll need them to stabilize him. You want to do an upper GI endoscopy. Although it is very obvious that his maybe upper GI endoscopy, although it's very obvious that his GI bleeding is from NSAID, it doesn't hurt to do a stool antigen for what? H. pylori. H. pylori testing, because you think it's still bleeding PUD. That's the most common. You want to do his other things like his BUE creatinine. Someone who has been abusing NSAIDs, you have to do his BUE creatinine. Okay, so you have one. Sometimes you may have to do his cycling. Okay, is that okay?
Yes, doc.
Okay. So how would you investigate this patient? It is a medical emergency. Upper GI bleeding is a medical emergency. And so cancel and admit, call for help, assign rules, primary survey, assessing. You're done. I'm not going to repeat that. And the next thing is to gain IV access and take samples for investigations. Take samples for investigations and then start your IV fluid resuscitation. If there is blood, you can give IV fluid resuscitation. Pass a catheter on that account. The resuscitation, of course, you are giving your IV high dose PPI. Of course, your transfusion, the blood is available. Please, are you all following me? High dose proton pump inhibitors.
Yes, doc.
And then you can do your upper GI endoscopy. Therapeutically. So, just like Rachel said, any questions so far? All right. So,
No,
just like Rachel said.
Doc, please, I have a question.
Go ahead. Who is speaking?
Rebecca.
Rebecca, go ahead.
Please, about the bleeding, how can you make it more clear than, because the patients can come in saying they are vomiting blood. Can you be more, as a candidate, can I be more specific in asking the color of it for the patient to describe exactly what they are seeing to help me with the diagnosis? Or when they say they are vomiting blood, I should just take it as blood?
I think I spoke about that. So the first thing you do is to actually get the color. What is this color?
Okay.
Is it bright red? I spoke about that, didn't I?
Okay. Oh, then I wasn't. I didn't
you
hear
missed
that.
it. Okay, you missed it. All right.
Yes,
so the first thing you want to know.
Thank you.
One of the things I said was that when someone says that he's vomiting blood, your first duty is to see whether it is varicial or non-varicial. And I said that although it is not 100% questioning to or differentiating marker, if it is bright red, it's most likely to be varicial. If it's altered or coffee ground, it is most likely to be non-varicial. So I've repeated it, okay? Yes.
All right, Doc. Thank you.
You're welcome. So at endoscopy, they can do injection therapy. Another thing they can do is thermal coagulation. Another thing they can do, like Rachel said, is to apply endoscopic clips. But all these should be prior to what? Given, or should be done after you've given your high dose PPI. Because remember, you need to use a Blatchford score to determine if this patient needs intervention. Sometimes they can apply a fibrin sealant. So there are others like hemostatic sprays and all that, but we will not go through that. So, I mean, the injection therapy, what goes into it? What goes into the injection therapy? So just like Rachael said, they can actually dilute adrenaline or epinephrine, okay, with normal saline. So you can actually do it with a diluted epinephrine or a diluted adrenaline. Is that okay? Or sometimes if you don't have it, you can use just saline. It's just that it is not so effective. Are we good?
Yes.
Are we good, please? Okay, all right. The thermal coagulation, they can use heat probes or contact probes, okay? Thermally. Apply thermal probes to achieve acute hemostasis. There are other weird things, but contact heat probes. Endoscopic clip is just a clip, like how those times your stapler, you call it, oh, clip, come and clip my book. Yeah, so you are clipping the mucosa. Okay. And it is the fibrin sealant too. It's also one chemical, fibrin-like chemical that can be used to seal the bleeding. Is that okay? And the last question I asked there, please note that the Blatchford score is used to assess the need for an intervention. Is that correct? Are you okay?
Yes. No.
Thank you. Any questions? Any question? Yes.
Yes.
I wanted to ask, in this case, if you go to an internal medicine station, you can still say a bleeding peptic ulcer.
Yes.
Or is that more? Okay, so it
Yes.
applies for both surgical and medical.
Yes. In fact,
Okay.
upper GI bleeding is managed by physicians. Get the principle. Upper GI bleeding, physician is a primary. Lower GI bleeding, which is not so obvious. Sometimes you can have melena and it's very obvious that it is from a CLD. That one you give it to the physicians. But lower GI bleeding, the surgeon is a primary. So the upper GI bleeding, if it's variceal or non-variceal, the physician has to see, and then he makes an impression of a bleeding peptic ulcer. So that said, the physician has to start high dose PPIs, and then the gastroenterologist, who is also a physician, can go in there, and then based on the Blatchford score, can give his interventions. But if all these things fail, the surgeon will have to come in and then maybe do some vagotomy or something. But if it's a perforated peptic ulcer, the physician is not the primary. And in fact, perforated peptic ulcer disease will not come with, or would very unlikely come with, upper GI bleeding, but will come with acute abdomen. And so, acute abdomens, the surgeon is a primary. Someone else had a question. Go ahead. If I've answered your question.
Doc, please,
Speaking. Who is speaking?
you gave a screen.
Queen,
The
yes.
Rachael, the Rachael and the Blatchford. I didn't get the what you said the Rachael would be used for.
Okay, so someone comes with upper GI bleeding. After your medications, maybe you give high dose PPI for your non-variceal, which is from bleeding PUD, or you give octreotide or telepressin for variceal Now, at endoscopy, would he need an intervention? Who will decide that? Blatchford. He answers the question, would we intervene? The Rachael score is only exclusive to the upper variceal bleeding, and it is most of the times applied post-endoscopy, but sometimes it is done pre-endoscopy. So you have pre-endoscopic Rachael score, okay? But the ultimate Rachael score will be done by endoscopy, because one of the parameters there is what? What did you find on endoscopy? Do you understand? So,
Okay.
do you understand? So after you have intervened, the Rachael score is asking, after you've used, so this time I'm talking about variceal bleeding. After you've intervened, the Rachael score is asking, you've intervened, but what is the patient's chance of rebleeding? And you know that once they rebleed, their mortality is very high. You understand?
Yes, doc.
So Blatchford intervened. After you've intervened, what is the chance that the patient will not bleed? What is the chance that he will bleed? What is the chance that he's going to die? Rachael. But note that we have a post-endoscopic Rachael and a pre-endoscopic Rachael. Because the decision is made at post-endoscopy.
Yes,
Am I
please.
communicated?
Thank you.
Welcome. All
Yes.
right. Any other questions?
Please, one more question. The the type 3C diabetes. Sorry. I wanted to know if in IMED you can mention chronic pancreatic insufficiency, like you mentioned, because I was thinking like anything with the pancreas to be like surgery or something, or we can mention it.
That is not correct.
Okay, so like pancreatitis and things can be mentioned in IMED.
Yes.
Okay.
That is not correct. Anything with the pancreas is not surgery.
Okay.
It's not surgery. The gastroenterologist is a physician. He manages chronic pancreatitis with the enzyme replacement and all that. Okay. Is any other questions?
For acute pancreatitis.
For acute pancreatitis, because most of them will present with acute abdomen, the surgeon has to see.
Okay. Thank you.
You're welcome. You know that they rarely go inside to go and cut the pancreas off for acute pancreatitis. You know that.
Yes, please.
Largely, the management is conservative, not surgical. But because it's an acute abdomen, the surgeon has to see. All right. Any more questions, please? Any more questions? All right. Thank you, candidate number 1.